We can go ahead and open the room at 7 o'clock.
Good evening, everyone, and thank you so much for joining us for our March edition of Diversability Unplugged, Disability and Bias in Healthcare. We're going to give everyone a few minutes to come in, but please don't wait to start connecting in the chat, letting us know where you're tuning in from. We have people from all over the world tuning into these conversations every month. While we ask for all mics to remain muted throughout the event, you can ask any questions that you have anytime throughout tonight's event in the chat for our speakers to answer during the Q&A section by putting a Q at the beginning of whatever text you type. That way we know to look for it. We look for those Qs in the chat so we know exactly where those are so we can pull them out and save them for later. On your screen right now is a graphic with a blue gradient border that features our powerhouse panel for tonight. The words, "Please keep your microphones muted throughout the event," are at the top in the border above the title, Diversability Unplugged, Diversability Unplugged, Disability and Bias in Healthcare. Below are 5 headshots, starting from left to right. I'll do a brief description of each. Dr. Nichole Taylor, she, her, from Wake Forest School of Medicine, who is a white woman with brown hair wearing a black blazer and a gold necklace. The seated nurse, Andrea Dalzell, she, her, who is a black woman with hair in a ponytail wearing a black blouse. Licensed psychotherapist Tessa Gordon, she, her, a woman with curly hair wearing red-brown dress. Chimére L. Smith, she, her, who is a patient advocate and speaker, who is a black woman with short hair wearing a black and white top. And Maria Town, she, her, from the American Association of People with Disabilities, who is a white woman with brown hair wearing a green top. Centered at the bottom underneath the photos are the words, "Join in our online community. Diversability Leadership Collective, get your first week free." Followed by https diversability.mn.co and our free Facebook group at https://bit.ly/diversability community. At the very bottom in the gradient border is a white Diversability logo. And we want to say thank you to our sponsor, Interpreter Now, for joining us for accessibility. We love Interpreter Now. We use them for almost all of our events for our community. We're so glad to have them here. So now that I've done the visual description of our flyer for this evening, without further ado, let's begin tonight's conversation. My name is Katherine Lewis. I am one of the content managers for the Diversability team. I'm so excited to be here having this conversation about equity and bias in healthcare with these powerhouse panelists. Before we dive super in depth on the conversation, I would love each of you to give a brief description, a very brief introduction of yourselves for our community tonight. And I would love to share, would love for each of you, I'm sorry, I'm tongue-tied tonight. I would love for each of you to share what the importance of healthcare equity is to you. I know that's a big first question to ask, but I think it would be a really good introduction to tonight's this conversation. So Andrea, will you please start with your introduction and answer why healthcare equity is so important?
Hi, everyone. My name is Andrea Dalzell, and I am known as the seated nurse. I am known for also being the first person with paraplegia to go through nursing school and become a registered nurse in New York City. Why is healthcare equity so important to me? Well, as a person with disability, I know firsthand, just like many of you, that when you go to the doctor's office and you can't get on that table, or they guesstimate your weight, or they don't understand what it is to push your chair or get the DME items that you need, it is not only a problem then and there, it becomes your lifelong problem because more issues occur when they don't know how to properly speak to you or assess you in a manner that's often left out of studies. It's extremely important so that we can get the healthcare that we actually need.
Thank you so much for that. Maria, can you introduce yourself and share why health equity is so important to you?
Sure, thank you. My name is Maria Town. I serve as the president and CEO of the American Association of People with Disabilities. We are a national cross-disability civil rights organization that advocates to increase the political and economic power of the more than 61 million Americans with disabilities across the country. And, you know, when I think about health equity, I think about the roots of ableism and stigma against disabled people. So often disability is viewed as the absence of health, and that's patently not true. For me, health equity is about actually recognizing that disability is a natural part of the human condition and ensuring that disabled people have the tools we need to manage our own health. And more broadly, that connects to our own ability to self-direct our future. A part of having access to managing your health is making informed decisions about what you want to eat, what you want to do the next day, and how you can plan for the future of your life, and either age into disability or grow old as a disabled person. And that's something that too few of us have had the chance to do. So. Thanks, Katherine, back to you.
Yeah, that was such a well-rounded, great answer. Tessa, can you give an introduction and share your take?
Yes, hi, I'm Tessa Gordon. I'm a licensed marriage and family therapist. I specialize in eating disorders, non-visible disabilities and chronic illnesses and trauma. And I come to this from my own lived experience as someone who's recovered from an eating disorder and also lives with multiple disabilities. And so why health equity is really important to me is both from my own experience, personally, from family members that are really dear to me, and also now as a professional on the other side in the healthcare industry and seeing the really the effects of the social determinants of health and the different disparities that lead into that, the way they affect access to care and treatment. I come from a real social justice-based philosophy, and I feel like, especially in terms of eating disorders and accessibility, we have a lot of social structures that need to be changed and looked at, and reevaluating the bias that people experience when they're looking at, weight, accessing care, treatment. Oh my gosh, insurance companies. I can keep going, but you said brief. And then we have, just getting care when you go to the doctor, facing weight stigma there. And then also with, you have a disability on top of that and facial pain and advocating for yourself and the stigma around that when you have multiple disabilities and illnesses that intersect. And so I look at the systemic problems that come into that, and I want to be able to help clients advocate for themselves. But now as a practitioner on the other side, I also want to be part of the system that's helping create change and noticing where we've really failed a lot of people and doing my part to help bring other voices in, make space for them.
Thank you so much for that. Nichole, can you give us your take and a brief introduction? And just a reminder, I know that a couple of us missed them, but can you please, in your introduction, do a brief image description for those who can benefit in today's event?
Yeah, I'll be happy to, Catherine. I'm Nichole Taylor, and I'm a white female with long, dark hair, and I smile a lot. So I am an assistant dean at Wake Forest School of Medicine. I work in the student affairs office. I'm an anesthesiologist by training. I was diagnosed with a disability after medical school, after training, and after my fellowship in high risk OB anesthesia, and I was diagnosed with multiple sclerosis 12 years ago. Due to my continuous deficits, I was unable to perform clinical care. So I shifted into administration, running a residency and helping train residents. And I desperately was seeking somebody who was a physician with a disability. Back then, it was really difficult to find someone who had experienced this, that was out public speaking about it, that I could just talk about, like, what do you do as a disability, as a single mom? Like, how do I, make sure that I can continue to have healthcare so that I can access my medications, which were $25,000 a month for MS to prevent relapses. So I think, I had all this wonderful background in medical training, but what I never had was a class on disability. And it was that lived experience of having it that I realized that it was very important not to use my training as an anesthesiologist, but as an advocate. As you know, there's lots of systemic issues and obstacles and barriers. And I feel that it's really important for us that see it, because I think people don't know what they don't know. So it's important that we lead and point out those barriers, if it's food insecurities, healthcare disparities, if there's other discrimination, problems with housing, all of these things I've actually encountered with students and trainees under me with disabilities. And so I just think it's important that we make these changes so that the next generation don't face the same barriers that we have faced.
Chimére, can you give us a brief introduction and image description and then your answer?
Sure, absolutely. I'm Chimére Smith. I'm in Baltimore, Maryland here. I am a Black woman. I'm wearing a pink shirt with hoop earrings. It's a pleasure to be with everybody tonight. I didn't put this in my bio, but I'm so honored to also be with Diversability because I did make the 2021 impact list. So it's truly an honor and a privilege to be here with you all today. In 2020, I caught COVID. I was a middle school teacher here in Baltimore for 5 years, looking for the trajectory of my career to be an assistant principal or a principal or a curriculum writer. But in March of 2020, I did contract COVID, and it completely changed. And like I always like to be honest, as an English teacher, I love words. It completely devastated my life. And so for the last 2 years, I've tried very hard as one of the first Black women to speak openly and publicly to the news media, to anybody who would listen, about the effects that long COVID now has had on me. As an English teacher, I don't like to mince words. I love words, but I don't mince them. And so it was very important for me to tell Congress last April that I was poor, I was Black, and I was disabled. And I make no apologies for any of that. And so when I think about health equity, I think about the fact that there's a presence of fear, but there's an absence of being scared. And what I mean by that is, I almost died at Johns Hopkins Hospital here in Baltimore, Maryland, because no one would take me seriously when I discussed the over 50 symptoms I presented to doctors and nurses and other medical staff in Baltimore, Maryland. And so my fear is that we've used all these beautiful words of equity and all these other things to describe our disadvantages, but we have to move beyond being scared to have these conversations about how each of us have experienced disparities. And so when I think about health equity, also as a teacher, I always think that how we teach about health equity and bias in healthcare starts in the classroom of sorts. I know that my students, when we would talk about disabled people or other students, there would be this gasping, this disbelief, this so much judgment. so much shame wrapped around it. And so I think if we started there, and even are not afraid to even take ourselves as adults into classrooms, we'll get an opportunity to really fight the stigma of being seen just as different or as other or as somebody on the outside. And so health equity to me is being able to face disability with fear, because we all have felt fear about our disability, but it means our doctors and our nurses and our other medical staff, and even, you know, people who are in charge of policy, we don't approach our disabilities as being scared. And so I'm glad to be able to discuss that with everybody tonight. And that's what health equity means to me.
Thank you each so much for your responses, for your introductions. We're again so happy that you're all here. I kind of want to segue the conversation that we just had about what equity means to each of you. And I think it's important to note that equity is such a broad term and it means so many things to each of us as individuals based on our lived experiences. And each of you have kind of touched on your definition of equity from the place of your own lived experience. And I kind of want to highlight that a little bit more with the question of, you know, what was the point in which, you know, what has your experience been with healthcare bias, with inequity in the healthcare industry from each of your own unique perspectives? And also, can you expound on not only what your experience has been, but at what point you realized that it was an issue that you wanted to address personally? Nichole, can you go ahead and get us started with that answer? If each of you would like us to call on you, that's fine. Or if you would like it to be much more fluid based and jump on in, feel free as well.
Yeah, I mean, I definitely know that there is, you know, inequities. And I think that one of the things that I have learned through my experience and that I see is it gets really difficult to navigate the healthcare system. And it takes a lot of resource, it takes a lot of times, and it takes also at times, you know, being connected. I understand that I do come from a place of privilege, being a physician who's continuing to work, who, you know, works with a major medical center. So for me to access healthcare is not a difficult thing, and I find it to be pretty seamless. But I do see that our healthcare system is very difficult to navigate. There's lots of hoops that patients have to go through. It's absolutely, you know, it's just ridiculous to me. And it's very frustrating for me as a patient with insurance and reimbursement. These are all very complex things. And if people don't have caregivers or others that they can lean on, it becomes a very difficult place to navigate. And that's why patients are lost to follow up and other things don't happen. So I do see how fragile, you know, that the system is for people who do not have the resources and the means to do it. And, you know, I'll be very honest, that's one of my fears, you know, as somebody who is a single mom trying to raise 2 kids. When they were younger, this was a huge fear of mine. Like, what am I going to do? And how are my children going to help navigate? So that's become part of my parenting, is explaining to them things way before any 18-year-old should know about durable power of attorney and things like that. We have unique considerations, and I just don't think that people really understand all of those things that we have to deal with being disabled, all of those decisions, and how I feel a lot of times afraid of going into the healthcare system without an advocate.
And you
Even
know,
as a physician.
I'm sorry, this is Chimére who's speaking. I agree with Nichole, you know, and that's what I meant when I said that we have to start. I taught middle school, so I would love to have started teaching. If I had known that I would have become a disabled woman, and even without becoming disabled, I wish that I could go back and teach my 12 through 15-year-old students about respecting and honoring people with disabilities and not treating them so otherized, right? And so my experience with healthcare bias, it took me by such surprise. Even as a Black woman who's experienced racism and sexism, which was one of the bases and the reasons that I became an advocate for long COVID anyway. I've been taught as a Black woman, raised by a single Black woman, that the key to my success was to graduate from high school, go to college, get a job, make good money, get health insurance, get health insurance, get health insurance. That was drummed into my head since I was probably about 10 years old. Get a job, get health insurance, and get benefits. As a teacher, I did not make a lot of money, but I had great benefits and great insurance. When I walked into Johns Hopkins the very first time at the end of March to describe my symptoms with COVID and long COVID, because I knew before doctors knew, I was treated deplorably. I was treated horribly. I was told that I was anxious. I was told that I could not get tested for COVID. I was told to go home and wait 2 weeks, and I was discarded and disregarded. Not just disregarded as a Black woman sitting on a medical table or on one of the medical beds in the cold, in the dark. I lost my vision for 5 months because of COVID, turned away time and time and time again. Not only did I experience that, but I watched doctors who treated white men patients, white male patients before me. I listened to doctors treat men before me. And so I experienced such blatant racism and sexism. Even when I went to the hospital and I stayed in the hospital for 8 days, I had a doctor, instead of listening to me when I told him I believed I had occipital neuralgia that came from COVID, he said to me, well, I went to the best schools in Baltimore. He said, I graduated at the top of my class at Johns Hopkins. He did not want to listen to me about my condition and my circumstance. But when they discharged me, on my discharge papers, what do you know? He says, oh, I believe you have occipital neuralgia. And so it has been my experience for the last 2 years, how sadly, and I've read this recently in research that I've done for this conversation, that the impression for Black people who seek care and treatment is that we are not going to take the advice of the doctors. And I find that to be disgusting. And so the way that I was treated, I was offered a stay in the psychiatric ward of Johns Hopkins, as opposed to people listening to my symptoms. That is exactly the way I was treated. Nobody wanted to listen to my situation. Nobody cared about the notes I kept meticulously on my phone. And my insurance card, my blue and white insurance card, did not do me any favors. And so that's the kind of bias I faced. And that is what I'm fighting for today. For Black women, Black children, Black families, not to be dismissed when it comes to COVID and long COVID. And that is, I agree with Nichole. Like, we just need to do a better job to educate our children about what disability looks like, so that we don't have adults who are walking around not understanding and not knowing how important it is to recognize who we are.
I agree so much. And I agree with, I think also educating the doctors on how to get out of their narrow tunnel vision of, here's one symptom. Oh, okay, this is the cookie cutter approach. I'm going to go down this book and just, this is the diagnosis. I feel like that is, if that's one thing that could change, like just one step would be a huge progress. I was trying to think on how to answer. Am I supposed to do an image introduction? Oh my gosh, so I got so excited. Oh, can I keep going?
You're
this is Tessa,
no,
curly hair.
You forgot your visual description. If you wouldn't mind adding it right before you answer this question, that would be very helpful. But yeah.
Sorry, I got faded and on a roll. Tessa, white woman, blonde curly hair, and in a rust sweater, and I have a million plants behind me. Okay, so I was trying to think also at the beginning how to answer this, and when did I first get moved to know I wanted to speak and kind of advocate and feel passionate about this. And I don't know that there was one experience. I've had many experiences with health. I start getting a little bit emotional, but I feel like one of the most recent ones was I live with glossopharyngeal neuralgia, which is a facial pain disorder, and how it presented, it's like along with it can be occipital neuralgia, and it was while I was in my internship for after graduate school, so I was working as a therapist specializing with eating disorders, and suddenly I get stabbing pain in my face. I can't swallow and I can't talk. Coming from a clinical background, I'm prepared to go to the ER. I write down everything that they will need, my name, the date, all my vital information in big letters across. I cannot speak, but I'm tracking all my symptoms. I'm waiting in the ER forever. It's not critical. They won't read anything. By the time I finally get in there, I'm holding up my notebook in clear paper, and they are demanding I talk to them and tell them what is wrong. As tears are streaming down my face and I'm struggling to get words out, with each syllable, it feels like somebody is stabbing me with an ice pick and blowing me with a blowtorch inside my face. They're then getting frustrated that they can't understand me and are walking away as I'm trying to describe my symptoms. I'm still with my notepad. It's all clearly written there, exactly what they need. I also know that pain medications aren't helpful. They're going to make me violently ill, and I can't imagine throwing up through this condition. Instead, they come in and tell me that I'm not being compliant. I'm not taking their medical recommendations. The male doctors are getting frustrated. Can't somebody be here to help you? No, I live by myself. I'm an adult. It takes 2 years to get the diagnosis finally and the care that I need. I'm the one who found the diagnosis, but I'm very careful to talk to the doctors because you don't want to tell them what the diagnosis is because it might offend them. So it's, well, could it possibly be? I'm wondering if you've considered, when I finally found the doctor that could diagnose and treat this, I was then put on a waiting list. At this point, I haven't been able to be eating or getting fluids. I'm losing weight. Coming from an eating disorder background, I'm advocating for myself for this. And weight stigma even shows up on this side where it's still not critical enough, right? Like, because they still have this weight bias where it's weight loss, but well, you don't look incredibly thin. So I'm asking for feeding tubes because I'm concerned about, it doesn't matter how you look with your body. The fact is, if you're not eating for 2 days, that's a concern, but we're going months at this point. I go into this great specialist who I will say he is now my doctor and we've worked through some things, but no offense to older white guys, but older white guy who, I'm a young female, and he didn't want to hear anything I had to say. He was the expert of my experience, even though he hadn't heard about my experience. I just remember leaving that appointment. I had so much hope to finally find this person who's going to help me, and feeling really heartbroken. And again, just one more area where no one was listening to my experience in my body, and feeling like, how was I going to navigate the rest of my life not being able to talk? I'd worked all this time to be a therapist and advocate for people in the eating disorder field and bring that lived experience forward. Now I have this lived experience I'm trying to navigate. And I think that was, for me, just one of the culminating experiences. So having doctors, if someone at the ER had just treated me differently, had taken the time to listen to my symptoms, to listen to the possible things that were going on, they would have known it wasn't a tooth thing. I wouldn't have lost a tooth unnecessarily and had all these extra things happen. I might have caught this sooner. So look, like, not going down this cookbook, cookie cutter approach, I feel like is one thing that's super important. And yes, I think teaching everybody to advocate for yourself, that moving away from this mentality that the medical professional field, and I throw myself in there too, that we're the experts. I do not think of myself as an expert when I meet with anybody at all. You are the expert of your experience. I really hope that I can ask you good questions that can elicit and bring forth your knowledge, and we can find that together. And I want the doctors and other people in the healthcare field to kind of move into that position too, and take more of a curiosity stance.
I love that. Before we get to the next person who's going to answer, I'm loving the conversation. Just a reminder, since we are doing round robin style discussion, before you start speaking, could you please announce that my name is and I am speaking, so those with access needs in the commentator status know who is speaking, since we have so many amazing guests today. Marie and Andrea, if you would like to answer this question before we move on, we would love to hear from you. Just that little side note, sorry.
Okay, so this is Andrea speaking. My brief description is that I'm an African-American woman with about mid-shoulder length here. I'm wearing a red sweater with a cream and polka dot shirt on in front of a bookshelf. In terms of healthcare equality, and when I first realized that I was going to advocate for this, didn't start because of the medical field itself. I actually wanted to be a lawyer. And I had told my doctors that I was going to come back and sue them for all the pain that they have ever put me through as a child, because I was diagnosed at the age of 5 years old with transverse myelitis and went through a multitude of different pokes, tests, prods, everything you can imagine, surgeries. I'm 37 surgeries into date. So as a child, I literally told them I was coming to sue them for all the pain. I don't know if I will ever recoup that, and that's okay. But I decided that when I went to my high school graduation, I was loaned out of the hospital. And I say loaned out because my doctors and 2 nurses accompanied me to my high school graduation. My doctor wrote in my memory book, please, anything but a lawyer. I think he knew I was serious because he knew that I had the most detailed description of every visit, everything that I had ever gone through. So I was like, I had a case when I turned 18 and I was going to go for it. But then in college, thinking about all of that school, it turned me off really, really bad, and decided that if you can't beat them, you have to join them so that you can do better. And I was determined to find the cure to pain. I was going to go to medical school, and in auditing a medical school class, I realized I hated the medical model. You were no longer your name. You were no longer whoever you were. You were a disease process. You became a cellular level of your whole self, and whatever the problem was is what they saw you as. If you had more than 2 problems, it was too much for them to handle. God forbid you came up with 10 problems. Yeah, no, you would need to be seen by 10 different specialists, and all of them would have to agree in order for you to even get 1 foot forward. And let's not forget about how insurance plays into all of that as well. Like Nichole said, I can have 10 specialists, but insurance will tell me that I only need 1. And then they would also have their doctors on their end trying to disparage what the doctors who are actually treating me are saying. So I became a nurse instead, because the nursing side, you have to take the holistic approach of the whole person and not just consider the cellular level of what is going wrong with that person. And please forgive me for the terminology of wrong. Nothing is actually wrong with us, but this in the medical field and in healthcare, it's what is perceived as wrong, bad, something that we shouldn't embrace. That disability is the issue and the problem that we need a cure for, and therefore it falls under the bad category. But circling back, in nursing school, not 1 class touched on disability, not 1 class touched on how to do an assessment on someone who may have had a stroke. No one taught me about disability in aging, just that you're going to age and that you should be perfectly healthy if you eat a well-balanced diet and you exercise. And that's what we're taught and continue to think, even though things go wrong with us every day. Of course, medical doctors, I'm not going to put them down. I work beside them every single day. There's some in the bunch that actually want to get down to the nitty-gritty of what's going wrong. But then again, the blockade comes with insurance. How much are they willing to pay? How much can you afford to pay out of pocket? And then can you get to that person to actually make the diagnosis come about? Every day right now, I work in ambulatory care, and this is just basic primary care services. And I am seeing how doctors don't even take a weight I'm seeing how a 97-year-old would have to be brought into the clinic when we have telehealth services now, and what a hassle that is to come to a clinic that's federally funded and waiting over 2 hours to be seen, for a doctor to only spend 15 minutes with you and maybe take on 2 of your problem issues and then address other issues at a later date. I see how every single day someone is writing wheelchair bound or all the outdated terminology that doesn't even make the basic assessment of what that person is going through on their daily life, but then getting orders to take different medications. That is not even taking into consideration how that person lives on a daily basis. So you've now continued the journey with me from self-perspective to wanting to be in the medical field, to then saying it's not for me, I'm going the nursing model, to now being in it and telling you at every single point, there's a hindrance, there's a blockade, there's something that's going to say you as a human being needs to be pure and whole, or you're too much of a hindrance, so we are only going to take a little bit of everything, and then maybe we'll try to piece you together. I am done speaking.
Well, this is Maria speaking, and as an image description, I'm a white woman with long brown hair. I'm wearing a bright pink floral print dress. I've got on bright lipstick, red lipstick, and some pearls. And I am in a corner of my bedroom, and occasionally my cat is in view. She's not right now, but if any of you are cat owners, you know you must acknowledge them when they want to be seen. So similar to Andrea, I was diagnosed disabled at a very young age. I was born disabled. I have cerebral palsy, and I was premature. I arrived almost 3 months early, and so I think everyone knew when I kind of literally came out of the womb that I would have some kind of disability. And Katherine, I have so many stories I could tell in response to this question, but you mentioned the first time that we sort of understood healthcare inequity and when we decided to work on it. So one of the things that's so true for so many disabled kids is that we have all of these procedures and we cannot consent. And we have no rights there. There are our parents or family members who are making decisions for us. Sometimes if they are doing what I would consider a good job, we are being included in those conversations and being told what will happen to our bodies or our minds. So I'd had a number of surgeries as a very, very young child. And when I was 10, I went in for a procedure that's called a bilateral tibial osteotomy. And it's a very long name for a surgery where they go in, they surgically break your legs, and they put them back together with plates and screws. This is a very intense surgery for a very small person. And, my mom did what I think she was supposed to do. She told me, like, here's what this surgery is going to do. Here are our goals with this surgery. What we didn't know until the day of the operation was that my doctor had brought in a resident to work with him on the surgery. And this resident told my mother to my face, like to her face, but while I was in the room, I hate children. I can't wait to get out of here and start working with adults. This is literally as he is about to slice open my legs, break my bones, and put them back together. My mom tells my doctor, I do not want this man operating on my child, right? And she did what she was supposed to do. At the same time, my longtime physical therapist, who was truly one of the brightest lights in my life, had asked to be in the operating room because she had a number of clients who were thinking about this procedure. She wanted to learn more. She was in the operating room And the only reason we know that that resident was also in the operating room was because she told us. The recovery on my right leg and my left leg, the left leg is who the jerk of a resident operated on, was vastly different. I have much better outcomes on my right side. And that was the first time that I felt totally disposable, right? And I was 10. Another story that's a sort of, it's a different lens, which is why I want to tell it. So like many disabled people, I received SSI, Supplemental Security Income, and Medicaid as a very small child. And I received SSI for a very long portion of time. But when I was a little bit older, Louisiana switched how they were managing Medicaid and Medicaid waivers. I was on a Medicaid waiver that allowed me to receive physical therapy and occupational therapy in my home. And again, I have cerebral palsy. You're not seeing me walk, but if you did, I mean, I wobble, you know, on a good day. I don't have very good balance. I now have to relearn how to do things like put on my shoes. And you have to get reassessed every year. And one year, the assessor said that I was too smart and I lost my Medicaid. I lost my waiver. And so I went without physical therapy, without occupational therapy for years and years and years, in part because my mom was a brand new nurse and couldn't afford to provide those services for me. And that was an arbitrary decision of the state to take that away. And that's the thing, like we've talked a lot about people in the medical profession and healthcare equity, but part of it too is that these systems are influenced by so many other people. And while some folks with cerebral palsy do also have learning disabilities or intellectual disabilities, not all of us do. If you meet one person with cerebral palsy, you've met one person with cerebral palsy. And so to this day, I've still had to fight to get things like physical therapy covered because, you know, insurance will only cover it for a couple of sessions, even though I have a lifelong disability. So I will stop there.
Before we move on to our next question, I want to express deep gratitude for each of you and your vulnerability to share your lived experience with bias and with medical trauma and the motivating factors in your lives to fight for change. These are incredibly nuanced discussions, and we are so grateful for you opening up parts of your lives to us to help advocate for so much of what we need to change for our community. So you guys have talked so much about like the intersectional factors of, you know, what brings about healthcare inequity and what it's like to experience these kinds of biases and these you know, so these nuanced and very layered factors that impact our lives as disabled people. This kind of brings me to my next question. You know, so many research studies have shown that not only in the medical field, but in many institutional places, there is deep-seated bias against disabled people at all intersections. And I'm curious to hear from you what you think contributes to these very well-documented trends of bias, not only within our medical professionals, but within the larger systems that impact health equity, and where you think addressing those biases begins. Let's start with Tessa, and then we'll go from there and get this ball rolling. I'm Katherine, and I'm done speaking.
I'm Tessa, and I'm a white woman, blonde curly hair, rust-colored sweatshirt, background with plants. Oh my gosh, you had me until the last part. Where do we begin? I'm like, I have answers, and then where do we begin? So I'll give all my ideas. Where we begin might be stuck, so I'm hoping other people know which one we will start with. I feel like so much of it comes from, so we can pick many areas. One, I think, is like, if you look at the research, that informs a lot of the trends and care. Research is done, like who's funding the research, what populations are getting studied. I think we need to change who's being looked at, who the research is by. I think it needs to start including more, and that then goes into the education resources, right? So like if research is only done by people who have PhDs or from like that level of education, who has access to that? No, can research actually include people who don't have to have a PhD? What about lived experience and combining people who are actually like bringing it back to those communities, diversifying who we're even diagnosing with the criteria. So if I use like eating disorders, if we've only, at one point, a lot of the research came from adolescent white females, well, that's where we're using all for our diagnostic criteria and using that as how we decide, you know, who falls within these basic dominant norms. Well, maybe for like 14-year-olds who are white and female, but what about everybody else who might be experiencing relationship with food and body? We need to start pulling in other people and areas and demographics. I think we have to look at media coverage. You know, when a news story reports on something, what language are they using? How are they talking about it? What media graphic images are they using? Look at movies. What stereotypes are they perpetuating overtly and subtly? I think we have to talk about it in schools. I think we have to think about how are we like interacting with different groups? Are we separating people? Are we talking, communicating across different groups? How much is that interaction happening? Are we bringing in trainings? Andrea, I don't know how many times you mentioned like you got no training about all these different, you know, about disability and other things in your program. Same with me, as in like I just forgot my degree, clinical psychology. Like, you know, we might get like a chapter that they say, you know, read this. And then if you want to learn more, you can go take extra specialization courses afterwards. But that really shouldn't be how it is. We need to start including this in the education, and we need to start at like a much younger age. I mean, those are just some, but I think there's so many more we can start with as well. But I will pass on to somebody else. I don't know if I have an answer of which one to start with. The media is a big one. I think that youth, and it's such a huge influence in our culture right now. And I work with so many clients that are trying to understand where these ideas come from. And when we start to kind of unpack the stories they hear and are aware of, whether it be from movies or shows or magazine articles, even things on the news, it's very subtle, but I think those get in a really young age. I think that would be a really great place to start targeting, and at least not having it keep getting worse. So that's one that I would probably pick to start. And I'm Tessa, and I'm done speaking.
Hi, I'm Nichole. I'd like to go next if I could. I'm Nichole, white female with dark hair and a black shirt. I really love this discussion. I saw that Katherine Lewis also mentioned in the chat that she loved it too. There are so many factors, is what Katherine said, and I would agree. So I'd like to kind of take it from the angle of being a physician with a disability. I had like talked about how I couldn't find a mentor or a guide or someone to help me navigate like what's next when you're, you know, have a degree that you can't use clinically. And so I switched into administration. And one of the first things I wanted to do was welcome the new class. And they asked me to speak about anesthesiology as a career pathway. And I also put my story in it. When I told one of my colleagues, they were like, I wouldn't do that. You know, it doesn't flow with what you're saying. They just asked you to speak about anesthesiology. But I talked about getting MS and about the uncertainty of the future, and that there are people that the students would encounter that have disabilities. And what I found is there were students that weren't plugged into disability service that came and disclosed to me. And I wanted to be that public face, even though I didn't really like the attention. I would have much preferred to speak about some type of anesthetic, but I needed people to know that they weren't alone. And if they were in medical school, I wanted to have open discussions about how we could help them if it was learn better if they have ADHD. And I wanted to get prepared for their clerkships if they were somebody who was ambulating with a cane or a walker, or if it was just an acute illness that was going to pass. So one of the big things that we've all hit on, Andrea, Chimére, Marie, Tess, is education. I mean, we have to educate. And so that's kind of how I feel we really need to educate the doctors, the medical curriculum, nursing, PA, PT, OT, pharmacy, all needs to include sections about disability and about approaching patients, understanding that we are all very different. But there are some common themes that I'm sure everybody who's listening and the panelists have already hit on. So on top of just being out there and being more public, one of the things that I also have started doing is research the prevalence of physicians with disabilities. And what I found is the early things were like 2% of people in medical school disclosed a disability. What's interesting is there's more things out there, like Tess was saying about marketing, like the Docs with Disabilities campaign, and normalizing disability, and also demystifying that you don't have to be a superhero to be a doctor, that we're real people with, you know, with feelings and emotions and depression and anxiety and MS, and maybe we have assistive devices. And so some of the things that I've published on, the incidence is actually 8.3% now of students who are disclosing. That number is still probably lower than what's in the class. But what I love about that number is that's 8.3% of the people in medical school that have a perspective that we're all sharing, and that can influence the system to make it better for the next generation. I'm hopeful. What saddens me, though, is that when you look at physicians with disabilities who are out in practice, it's only 3% are disclosing. I'm sure it's higher. But what I want is institutions, residencies, medical schools to be more proactive in their messaging, to be more inclusive, to welcome students with disabilities, understand that they have a unique perspective. They'll teach their classmates, they'll teach their faculty members, and they're going to teach the leadership, and they're going to influence what healthcare looks like in 2030. I think it's important that people with disabilities are brought to the table to solve problems. And I think that's one thing I really try hard, is to make sure that somebody with a unique perspective is in the room. And I hope one day that I'm not the only one in the boardroom saying, hey, we need to throw disability in that equity and inclusion effort we're doing. That's when I know there'll be success, when I'm not the only one, the physician with a disability, reminding leadership that, you know, we need to include it when somebody without a disability beats me to it. And I'm Nichole, and I'm done speaking.
This is Andrea, and I'm gonna pick up where Nichole just left off. So for me, education is, yes, the basis, and representation, and we think about that in social media. But if you don't see it in history, you're not gonna see it in media either. And that's just the baseline. And this is with not even being in healthcare at the very beginning. Very few Americans, and I say Americans intentionally, can't even tell you which president actually had a full-fledged disability, but history has covered its tracks to kind of make this facade that what he came up with was all because he was perfect in every way. We forget that he had the touch of polio, and he used a wheelchair, but then they try to give credit to his wife for running the government for that period, when he's the one that came up with the social systems that we use today, and what has continued to push forward, but is being dismantled slowly within our congressional representative hands now. So let's just start with the history and making sure that disability history is not erased, because if you learn it as a child, you're bound to understand it as an adult. And even if you didn't understand it, you'd be more accepting of it. So then when you push through to higher education and you decide on the path of healthcare, you are going to be exposed to different disability from the very inception of education. I think that's the basis, because again, that's going to seep into social media, that will seep into the books that we read, that will also ensure that someone has been exposed to disability long before they decide that they're going to be a caregiver, a healthcare worker, or someone working on the population as a face forward saying, I'm here to help you. That means you've already been given the background information for someone who may have been hard of hearing, mobility issues, aging into disability, and what that looks like, even just in ageism. we're thinking about a system that has literally erased what we go through on a daily basis as if they're never going to go through it. It's not a if you're going to have a disability, it's a when. And we know this, but no one plans for it. And if you continue to negate planning for disability, healthcare is going to crumble on itself. And we're seeing that now with how COVID has come about and the implications that COVID has brought forth for a lot of people who were considered healthy in the eyes of healthcare. And now moving forward, what that actually looks like and the pressure and the burden it's putting on a system that is already top heavy with I want to say the normal basket of the problem list, which is hypertension, which is high blood pressure, or, diabetes, what some people call sugars, right? Like there's a host of natural things that affect human life, and then disability is the added tax. We're all human, but can you just for 1 second in healthcare think about what it would have been if they were exposed to disability and how the education in the medical model could have actually exploited that education so that they would actually consider for a moment different disabilities in their education and how that education now impacts what they're thinking when they're trying to find that cure for cancer or that cure for pain or that cure to walk again. What does that push for them? I'm Andrea and I'm done speaking.
This is Chimére. I'm speaking now. I have this pink shirt on, short fade, hoop earrings. I love what everybody is saying. And I really feel so inspired by this conversation on a level that I haven't felt in a long time. As we all know, advocacy can get quite hard. You can go broke being an advocate if we're going to keep it real tonight. And I like to keep it real. I don't like to mince words. In the words of Iyanla Van Zant, I like to call a thing a thing. And so my thoughts about how we can move beyond health biases is in the long COVID space in which I find myself as a first waiver, meaning I was one of the first. There's a group of us who got sick anywhere from maybe December 2019 with COVID, 2019 through March of 2020. I'm a first waiver. And one of the things I was so impressed by, even as being a participant in this movement, is how much patients have galvanized together to tell our stories. I have never in my almost 40 years of living seen a movement of a health crisis that people have come together on every side and all types of vocations and all kinds of experience get together and move policy so quickly, move people's hearts and their attention so vastly as I have in long COVID. And I remember as a Black woman, there's certain things in my community, in my circle of friends that I do, and we do. So I do a little neck rolling. I do a little girl, you know what I'm talking about. I do a little, eye rolling. But you know what I found with my attitude that I had as a Black woman? I was afraid to take that same attitude most of the time to doctors. And what I had to do in my illness, I had to get angry enough and take some of that attitude in those medical offices when people were turning me away. I was blind in my left eye for 5 months. 5 months. Nobody, not even eye doctors would acknowledge that COVID caused an inflammation in my brain that caused me to go blind for 5 months. And so this angry Black woman syndrome that people like to use and misuse, I had to get angry enough in my conversation. I had to get angry enough by writing Google reviews on doctors. And I would bring that back to the group, a long COVID group, Body Politic, which I'm now a board member of. And I've never seen on social media how, just the like of people who were like, look, we got to get something to happen. We got to get this ball rolling. And so we did that on Twitter. We did that on Facebook. We did that now in Slack. We did that. We wrote letters to the NIH and the CDC. And so, as Tessa said, we have to start looking at different vantage points and different voices, because a lot of times, as one of you all said, if you don't have a medical degree, people don't take you seriously. But in the last 2 years, long COVID patient advocates have conducted their own research. They've written, and they're in the, some of us in the process of writing books. We've spoken before Congress. We have completely gotten the attention of the NIH to change some of their policies on how they do research, who they include, and to investigate why they're not including more Black and brown people. So there's been a movement because the lenses are changing, right? So that's one thing I would like to see us do more of, to give more of a microphone to the patients, because we, of course, know what we're talking about. Secondly, one of you all talked about the media. In Baltimore City, just probably about 2.5 months ago, the Baltimore City Health Department just did a very, I'm going to be nice here, a very introductory introductory conversation about long COVID. And it was not reflective of the diversity and the inclusion of what the condition looks like. I was watching a white woman who was affluent, who had money, who had success, tell her story. And I asked in the chat, I said, but what about the other patients? This is not a white woman that's affluent, is not she does not represent Baltimore City alone. Right? There are impoverished people here. There are more impoverished, more unemployed people in this city, more Black people in this city. And yet I saw nothing that reflected me or looked like me in that conversation for an hour. And so one of the reasons why I decided to speak out was because every story I read about COVID with my one good eye, every time I would turn on CNN and listen and see and kind of peek out of my eyes, I never saw Black women. And I was like, what in the hell is going on? I got to see somebody that looks like me, because as Andrea said, historically, and this is the part that pisses me off, is historically, Black women's conditions have never been regarded with care. We've never been endometriosis, miscarriages, pregnancies, cancers, now long COVID. We're never given the same access, the same education, the same information as white women. And so I got angry enough to say, I need to see myself. I need to see my students. I need to see somebody that looks like me on these TV screens. So my purpose was never just to be some media darling, right? My purpose was to show another Black woman, another Black family, another brown family, that this is my experience too. And that although our races are different, our ethnicities are different, these are still some of our shared experience. So the media definitely has to continue the process of including other people, other vantage points, other experiences. And the last thing is, I would say, because I'm a note taker, I like to take notes of this. I'm such a teacher. We've got to move beyond these words, because I've read some great articles that the NIH and the CDC wrote in December of 2019, and then they wrote them again early 2020. December 2020, and they wrote them again in December. The middle of I have a memory problem with long COVID, so please forgive me. The middle of 2021, they talked about how we know for a fact that the BIPOC community suffers more with COVID and long COVID. And yet nothing has changed in the last nothing has changed. We still don't have demographic information about how many Black and brown people are affected by COVID. We still don't have it. And it wasn't until Ayanna Presley, Representative Ayanna Presley, wrote a letter to the CDC asking them for the information that anybody was even going to start to explore that. And so we have to start writing these beautiful flowery articles, and we have to get real. And I also think my last point is we have to expand the topics in which we discuss disability. I wrote an article recently that talked about what it was like for me after 2 years of being alone in a room, sick as hell, hearing voices, seeing figures, so sick that I had lost 20, 30 pounds, which I've gained back, plus, and then some, at a psychotic break because of COVID. Now that we know that COVID causes brain inflammation to the point where it causes psychosis and delirium, right? After being in my room, in my godmother's basement for 18 months alone, I got so lonely. I had lost my boyfriend. He had dumped me at the height of my illness. And I wrote an article recently that was posted in She Knows, talking about what it's been like in the last few months in a relationship, a new romantic relationship, and having to ask for physical affection. As a Black woman, I've never had to ask anybody to hug me, to love me, or touch me. And so I think we need to get real about the top. We have to start expanding our topics, because if we don't start expanding our topics, then people are going to do it anyway. Even before I became disabled 2 years ago, I just want to sit here and be honest. I looked at disability with such a bias. I'm almost ashamed to be here because I'm disgusted at just how limited my thinking was. But having conversations about physical intimacy, I'm not talking about sex, I'm talking about just somebody to touch you, what it's like to not be touched for 2 years, what it's like to have to ask your family members for hugs, what it's like to be the only a research group of full of people who struggle with fatigue and other illnesses, creating their own research. And so we have to just be okay with talking about a myriad of topics that are centered around disability, because there's so many things that we don't discuss, especially in my community, because we're so used to keeping things a secret. You know, Black women don't come forth because not only do we not see people that look like us, but we also have been told that our stuff doesn't matter. And so we have to become very, very avid about making sure that everybody's stuff matters. And I'm done speaking. This is Chimére.
Thank you all so much for this conversation, for your insights, and for sharing so much about your experiences and what you think the road forward is. We would like to move on to our Q&A. We have some phenomenal questions from our attendees this evening. So if you don't mind, let's go ahead and get started with a few of those. I will ask a question and I'll field the question to you. And then, just like what we've done, whoever feels compelled to answer will do so. Just let us know who you are and let us know that you're speaking. You don't have to continue to do image descriptions, just so you know. Our first question is from Brittany. They have a question. They say the fight for advocacy for yourself is exhausting. What resources and/or strategies have you found to be helpful in your own personal advocacy efforts to help with that exhaustion and fatigue that we so often experience?
I'll go. This is Tessa. So the best piece of advice I got was from someone named Vicki Reynolds, and she described it as, you need your howl at the moon person. And this doesn't have to be your best friend, but it needs to be the person that you're going to call and can howl at the moon. So vent, sound crazy. It's crazy, and I don't like to use that word, but she used it in this description, crazy. And know that they aren't going to think you're crazy and call like the police or call and say, we should take you to the psych ward, right? That like you can say whatever you're going to need and they know you're just howling at the moon, and that they are your container to hold that. And I loved that. And so pick that person, pick your Howl at the Moon person, because we all need somebody who can be that person. Other thing I would say is know, like for me, know what like rejuvenates, what fuels your soul. Someone, was it Maria? You mentioned you had a cat. I don't know if that for you, like, so I have a dog. Aspen actually has been sleeping, but I have the most beautiful German Shepherd, I think. And he is definitely something that helps me like just check out and put all this stuff on pause, because he finds so much joy in the moment. Like we can do the same walk every single day. And when we get outside, it is Disneyland, and he just smiles at me and loves me. And I can be sobbing and overwhelmed. To be totally honest, I have been completely overwhelmed up until this point. I had a really rough couple of weeks with advocacy work on behalf of some clients, and had some horrible experiences with medical community where the clients aren't even mad yet, but I've been so mad. I've been crying every morning on these hikes with my dog. And I just look at Aspen, who's so happy, and he just brings me back to my center. So I think those are the two things. And then my third is I like bubble baths. So those would be my three like kind of fun tips. There's many more, but those are the things I enjoy. Oh, Tessa, I'm done speaking.
I'm Nichole Taylor, and you know, for MS, fatigue is also just a really tough thing. I mean, I really have to pace myself. When my daughters were young, I'd be like, I have an energy bank and it's only this, you know, it's this much when it's full, but I'm like right here right now. So I can spend my energy picking toys up after you, or, you know, you can help me and we could do something fun together. And it all goes down to energy. And so I find that if I'm, you know, I'm a big, obviously medical, you know, institution utilizer. So, you know, a lot of my frustrations come around insurance and pre-authorization and medications that aren't covered, that type of thing. And I find that I try to do those tasks in the beginning of the day. They tend to be very draining. And if I put them off to the end when I'm already exhausted, things are really tough. So I try to prioritize those things that just are, emotionally a reminder that I have a disability that will never go away, and that will, you know, this is kind of a little part of my future as I age with MS. So I try to pace myself, and days where I'm already kind of emotionally spent, if it's at work or other things, you know, I put off some of those tasks. So I really try to pace myself and do those types of things. The other thing is, a lot of like the MS community is I've met some wonderful people there. Having others that have a shared experience and can relate to a lot of what you're going through. If it's a Facebook community, I think with me, I've been changing MS medications a lot because my previous medication wouldn't allow me to mount any antibodies against COVID. So I'm hoping this next one will. So it's nice to go on those groups and find out what are the side effects they have with the medication. You know, all the things that, you know, even though I'm a physician, I want to hear it from the people who experience, because they know that if you take peanut butter with this medication, you're going to have less side effects. You know, that's not in the pharmacy brochure. So I feel like leaning on people with experience, people who've done that before you, and then sharing your experience for those behind you as well. So that's kind of how I fill myself up too, is by giving back to others and try to make this landscape easier for others. I also love bubble baths, Tessa. So that's all I have to say.
Do we have any others who would like to answer that question before we get to another question? Yes, Maria.
This is Maria. So a big thing that I have to tell myself every single day is that advocacy is a marathon and not a sprint. And even if the problems are so urgent, it's still a marathon. And I'm gonna use this response to like kind of answer the last question too. I want to give you all an example of this. So COVID happens, COVID's still happening, COVID happens, but we find that every state in the country has started to authorize these things called crisis standards of care. These are policies that hospitals can use to say, okay, we've got a shortage of medical resources. We will deny certain people access to life-saving treatment, right? And those certain people most often were disabled folks and older adults. But in reality, it's disabled people of color, disabled fat folks, right? LGBTQ, particularly trans people. The disability community engaged in such incredible coordinated advocacy on this issue for 2 years, right? Trump administration, Biden administration. If we had one policy ask that every disability community organization under the sun agreed on was, we need federal guidance on crisis standards of care so that we know we can go to the hospital and people will not ultimately just assume it's okay for us to die. After all of that advocacy, what do we get? We get FAQs that are not legally enforceable, right? When I tell you all, I cried and screamed for one day, and then I cried and screamed for another day. But that next day, I had to go sit in front of the Secretary of Health and Human Services, put a smile on my face and say, thank you. I had to remember it's a marathon and not a sprint. And part of it is actually valuing myself enough to know that if I don't prioritize my own wellness, broadly defined, I won't be able to wake up the next day and continue the journey. And so I also try to create space for other people to acknowledge that about themselves. And I will stop there. So I think, Chimére, you wanted to speak.
Yeah. Maria, girl, you better preach. Anyway, I wanted to say this too, because, you know, I am a Black woman, and I just want to, you know, say that sometimes our paths are different. And so what I will continue to say, because oftentimes Black women are not historically believed, Black and brown women, is that we have to start, I hate to say this, God, I hate to say this. We have to start CYAing and you know, covering our butts, right? And what that means is, it's so sad that I have to take phone notes and all these records on my phone to doctors to get them to listen and pay attention. But I have to do it because otherwise there's an assumption that I don't know what I'm talking about, because I don't come with all this research or all of this medical data that I am expected to have, that maybe a white woman or another woman may not be expected to have. And so that's important that we do that. It's important, you know, what makes me very sad as I just received Social Security is that my fear is that our government still doesn't recognize invisible illnesses, right? So a lot of my friends will say, girl, you look good. Oh my goodness, I'm so proud of you. You look so good. And I'm just thinking to myself, if my friends who love me and care about me don't understand the magnitude of invisible illnesses, can you imagine how much our government, as I think Andrea said, talking about how our government is already overwhelmed and impacted by other illnesses. So we have to find a way. So I wish our Social Security Administration and our other major health organizations and social service organizations would recognize the fact that a lot of times, and I just read this in research, that Black and brown people suffer from invisible illnesses more, right? Depression and other mental health issues. And so those have to be recognized. We have it on paper, but we don't do anything about it. And lastly, howling at the moon, as Tessa said, we also have to be okay with supporting in this country, in our friendship circles, telling people our boundaries. That means finding out what our boundaries are. Before I became ill, I was taking over the world. I was hanging out with my friends. I had a boyfriend. I worked my job as a teacher 6 days a week on Saturdays, sometimes Sundays. But as a Black woman, it is difficult for me to sometimes say, no, I can't, to put a stop on it. And so we have to become very comfortable with identifying first what our boundaries are, and then being able to tell other people. We don't want to disappoint people, but sometimes you got to get to the point where you just have to say, hey, it's about me, and that's it. And Maria, I agree. You know, advocacy, it's like I said, it's tough work. And so being okay with sometimes telling people no in an advocacy space, and that's okay too. Giving ourselves that kind of permission to not be used, to not be abused, because sometimes people in advocacy will do it too, right? They'll take advantage of you because you're Black, because you're this, because you're this. And we just have to become clear about saying, no, I can't today. No, I won't take on another project. I'm tired. I'm not feeling well. I don't want to be bothered. And it has to be okay. We cannot be continuously judged for that, or shame for that either. So I'm done speaking.
I love that. All of those answers are so awesome. I would like to get to as many questions as we can. I want to ask another question. And I think this question is very fitting because it is also Endometriosis Awareness Month. This is in regards to disabled women's and female identifying people's reproductive health and justice. This person says, I'm a disabled woman and I'm a PhD candidate. I'm the only disabled researcher on my team. I've noticed that in terms of disabled women's reproductive health, in all healthcare, we face discrimination and unequal access. But there's a growing amount of effort and time spent on two things: medical training curriculum, including disabled folks, and improving the doctor-patient relationship and communication through training and competency frameworks. Do you think any of these efforts will actually help? And what, if any, things can be done by researchers and academics to improve this relationship and these efforts?
I'm going to jump in on this one. This is Andrea speaking, and I'm going to say all of it. Yes, they all work. And the reason why is because when you are building medical curriculums, no matter which way, whether you're doing a study, whether you're doing any part of it, qualitative, quantitative, all of it matters, because if you include disability, we include everything else: white, Black, Asian, female, male, non-gendered, like we're including other studies. We even include LGBTQ now. Okay, but you don't include disability, which ties all of them together. So if you're going to take your population that we're studying or you're writing about, or the patients that are coming into the clinic, or the medical schools that are going to be taking in residents, or the students that are going to be learning from the textbooks, you need to start with that disability factor, that you can have hearing issues, visual issues, pain issues, skin issues. There can be a multitude of different issues that cause a multitude of other different abilities. And if you're going to do a study, don't just close it off, because you need to understand that if someone in that group has a disability, you can now make sure that the study involves that one person with a disability. And when you publish and it goes in a journal, someone else can then read it and say, oh, hey, this one person had this in this particular study, and these are the facts that they saw. So then if one person across the nation, across the world, has the same implication happening, guess what? Scientists can now go back to that study and say, oh, there's one other person there that has these same exact symptoms or these same exact implications. And now you're moving the bar forward, because now you can say we can study two people, or we can get the names of those two people, or move anything else forward by putting it in the media, which we all can access now, putting it online so that people can find each other. We have all of these ways of connection, but yet disability is always disconnected. You have to connect us. If you can't connect the dots, we're not going to move forward. So study curriculums, journals, studies, we have to stop separating just based on the description factors: white, woman, male, female, Black. It doesn't matter anymore. Add disability to that too, because disability is going to wrap us all together.
Yeah, this is Nichole, and I want to segue from what Andrea was saying, because I want to approach it from a little different angle too. You know, the reason why I think that disability tends to be excluded in research studies is because we have to admit that the history was that disabled, patients were not treated as human, and there were things that were inappropriate that were done to them. And so that's a special protected population. But the downside of doing that, instead of just making sure that all the studies for every population is done fairly and with caution, the problem is when you don't study that patient population, then when you do get something like COVID and you exclude everybody with a disability from the vaccine studies, then they don't know how to move forward with patients who have disabilities. So then what happens is this entire group of people isn't informed on how this new vaccine is going to affect them. And so with all of these patients who are immunocompromised, they were really late to the game to say, hey, this vaccine may not work for you. You may be more at risk. So when everyone in the country is pulling their masks off, I was gasping, because I suspected that the patients who were immunocompromised, like myself, because I happened to be checking my antibodies, that there was a problem with our medications. And so I was writing CNN. I was trying to kind of raise the alarm that as people were becoming more free, that the most vulnerable amongst us were going to have a higher chance of getting COVID, higher chance of having adverse effects, a higher chance of dying. And so there's a huge risk when we exclude an entire segment, because those people then can be harmed. And that's exactly what happened with this pandemic. And so I think we have to acknowledge why they were excluded, but I think that we can do better in including them in a safe way. So I love what Andrea said, but just another viewpoint too. This is a great discussion. And now time for someone else to share their wisdom.
This is Maria. I just want to put something out there. So I agree. I think the kind of education piece for physicians and other medical professionals is so important. I think diversifying who is in clinical trials is essential. But one of the other reasons that we don't see disabled people participating in research and clinical trials is because a lot of these spaces where they're taking place are not accessible, right? There are guidelines for accessible diagnostic medical equipment, but doctors' offices don't have to actually have that equipment in their spaces. For a hospital or for a doctor's office, the waiting room has to be accessible, but the patient rooms don't have to be. So how can we have the expectation, like even if all of the researchers in the world said we want disabled people in our clinical trials, whether it's people with cognitive disabilities who struggle with things like fluorescent lighting, right? People who are immunocompromised who might have trouble in a group setting, folks like myself who can't get onto an exam table or who can't put my feet in stirrups, going back to the reproductive justice thing, and so I want to take this opportunity to put a couple of things on people's radar. The Health and Human Services, I'm going to say them again, they're going to come out with a rulemaking on section 1557 of the Affordable Care Act. And that is the section that focuses on non-discrimination in healthcare. So things like ensuring that diagnostic medical equipment are accessible, like telehealth is accessible to people with a variety of disabilities. Things like crisis standards of care and addressing those, all of that can happen in this regulation. Is it going to fix everything? Absolutely not. Do we need it to exist to create a path for change? For sure. And providing a comment to the federal government sounds intimidating, but it is one of the ways that our democracy works. So even if you go onto their website and share your story, that is really, really important. And I hope you all will be on the lookout for what AAPD is going to do to help support people provide their comments for this important rulemaking. And I'm done speaking.
Are there any others who would like to answer this question? I'd like to get to one more question very quickly before we end, if that's okay. Okay. I think this last question is something that we can all relate to, at least most of us. I don't want to speak for everyone, but we have someone that asks, can you please share your thoughts and experiences with internalized ableism in your healthcare journey, and strategies that you find helpful for how to overcome that in helping to move the process for health equity forward?
I'm going to ask for a repeat on that.
Okay, sorry. We have a question. What are your thoughts about internalized ableism? So the ableism that we experience in ourselves through our own journey. And how do you feel that you and others can overcome that in the journey towards equitable health for disabled folks?
So I'm going to jump right in. This is Andrea speaking. So I think every day I fight with internalized ableism. So I'm going to put that out there first. I fight with that every single day. When I was in the very beginning stages of nursing school and everyone was telling me, the professors, the counselors, the disability office, everyone was saying to me that I wouldn't get through nursing school because I wasn't able to do CPR. So they thought, or I wasn't going to be able to ambulate a patient or turn a patient in the bed or get to an emergency if it were happening. And I started to listen to all the things that everyone was telling me that I could not do. And I was starting to lose the piece of me that knew everything that I could do, because I kept hearing all the things that I couldn't or shouldn't or never would be able to. And then one day I just said, enough. You don't know me. I don't even know me. You can't tell me that I can't do something because we're working in an evidence-based practice. Nursing is evidence-based. Healthcare is evidence-based. Medical, anything is evidence-based. I was like, please show me where someone couldn't do something and let me see what they did so that I would do it differently. We put this emphasis on people that they have to do something the exact same way that someone else does it in order for it to be considered the right way, the normal way, quote unquote normal, or within this realm of perfection. No one does anything the exact same way. Not even walking is done the same way. So why was the expectation of me being a nurse going to be the same as someone who was standing up? Their perception was of just someone standing up doing the job, not of someone sitting down. And so they could never fathom, or creativity could never be brought to light to say someone sitting down could do the exact same job. It was just an assumption that we couldn't, or I couldn't. So then you fast forward to where we're at now. And I am a nurse. I've been a school nurse. I worked COVID ICU during the peak of New York's pandemic. And I work ambulatory care now, where I'm constantly ambulating patients, getting the patients in crisis need, and proving to myself every day what someone or a lot of people once told me I wouldn't be able to do. And that's because I stuck true to me, knowing what I am able to do, what I can and cannot do, and setting up those boundaries like someone else mentioned before. You have to set those boundaries in place to not only protect you, but to actually just hold true to who you are in any facet, whether it's in healthcare, whether it's in school, whether it's on social media. You have to have those boundaries. So yes, I set major boundaries for myself. I made sure that I knew that if it worked for me, then it was going to work for me. And if it didn't work for me, then I was going to move on. But no one was going to take the opportunity away from me to try. And that's the bottom line. That's the foundation of anything that we do, is to just try. So it goes on here with that ableism with me that I face every day. Well, will I be able to reach that medication on the top shelf? What's going to happen in the event of emergency? Will I be able to do it? Guess what? No one has the answer for that, whether you're standing up or sitting down or with a cane or without a cane. Can you see? Can you hear? We don't know. We don't know. When we're put into a situation is when we find out, right? And we prepare for that the best that we can. So I have to tell myself that every day to kind of just fight that internalized ableism. Like I am in the same boat as anyone else, despite my own obstacles. And I'm done talking. Thank you.
And Andrea, that was a beautiful answer, beautiful response. And it just made me think too about my pathway and how I look at myself as with internalized ableism. For about a year after I got sick, I thought to myself, as I've read, I obsessed with all the medical journals and articles and facts, and I was on in different long COVID groups, and I was trying to ingest everything that I could possibly learn about the science and research, and I was really driving myself mad, if I could say that. And I had to really, and it just in the last 6 months, I've started to really ask myself who I want to be in this journey and this advocacy and in this walk. And the truth of the matter is, I'm not a scientist. I'm not a researcher. I am not a policymaker. Ever since I was 5 years old and could read for myself, I love to talk, as you all can see. I love to read, and I love to express myself. That's the reason why I became a teacher. And so I also too have to fight the fact that I don't have to know all the research. I don't have to know all the science. All I can do is be myself. And so for me, what that looks like is exploring, as I said before, the different topics that affect myself and other people who experience disability. And right now, my best friend and I are working on a project about looking at looking at and lifting up the our definition of a caretaker. Who's a caretaker in our lives? And I thought to myself, I said, if all I can do is write about my experience as a Black disabled woman who's now, I'm low income, poor now. If all I can do is talk about how asking for physical intimacy in the last 2 years has changed my world, changed my life, reconnected me with my family and my friends. If all I can do is get on Twitter and say that this experience needs to change, then that's the best that I can do. And I have to be okay with it. I can no longer take on the same attitude I took when I was quote unquote healthy. And so I struggle with it too. And trying to fit in, trying to assimilate still is quite bothersome for me. But each and every day, I'm learning how to accept what my portion is. I grew up, in a Baptist church, and we always talked about what our portion is. And my portion is just that: the writing, the speaking, the educating from my vantage point. And so that's how I work towards defeating my internalized ableism. And I hope that it inspires somebody else.
Thank you all so much. This is Katherine speaking. We've gone over a little bit on time. I apologize for that. I want to thank you all again for being here, our amazing guests, our interpreters. Thank you so much for helping us keep these events accessible to our entire community. We didn't get to all of our questions from our community, but if you would like to continue the conversation, we encourage you to check out the Diversability Leadership Collective. It's a community where you can continue to have these conversations, have access to amazing opportunities, other events like this, exclusive access to other resources for the community, and also join our free Facebook group. Those links are both in the chat. We will paste all of the additional community questions in those forums later so that you can continue this conversation after the event. And again, we want to thank all of you for helping keep this organization going and helping us to elevate disability pride together. Thank you all for being here.